next session. Catch up. So if you want to have some new scenes. Alright, so we'll go ahead and get started. This next session is going to be focused around financial incentives and financial reform regarding zero-dose programs. So things that can be done to improve the performance of zero-dose programs or improve the efficiency of those programs. So without further ado, I'll introduce the speakers and we can go ahead and get started. So the first speaker who we'll have is Saffana Mahmudah from Chai, Indonesia. Presenting on unraveling the cost of reaching the unimmunized children to inform financing reforms in the region.
Okay, hello everyone. My name is Saffana from Chai, Indonesia, and today I would like to present to you our work titled Unraveling the Cost of Reaching the Unimmunized Children to Reform Financing Reform in Indonesia. So I would like to give you a brief explanation about the zero-dose conditions in Indonesia. So we have nearly 1 million zero-dose children in Indonesia, which accounted for more than 25% concentrated in West Java, Central Java, and East Java. In Indonesia decentralization context, the national governments are responsible for the vaccine procurement, while the subnational covers the operational and also healthcare service delivery for immunization. And subsequently, the Gavi supports has ended in 2018. So the sustainable immunization for costing and financing is really important, both for the national and also for subnational level. Okay, so our work has three objectives. The first is to validate zero-dose children at the PS level by the data triangulations. And the second is to create the data-driven activity planning, costing, and budgeting for ZD intervention. So first, we conduct the situation analysis, followed by the bottom-up costing approach for operational costs, and also prioritization intervention to be integrated into PSC annual work plans. And the third is to map and mobilizing the resources and identifying the funding gaps. Currently, our work is catalyzing the budget dialogue and funding reform at the district level. And our methods, we collected the data via a series of workshops since November last year until May this year by the online spreadsheet to ease the provincial health office and also district health office to monitor the data. And we adopted the WHO CMYP framework to develop the immunization cost plans from 295 PNC across 12 districts in 3 provinces using bottom-up costing approach that include the vaccine procurement, disposable medical supplies, which are currently funded and distributed centrally, and health personnel costs. And to guide structure analysis and PSC level, we employ the WHO health system building blocks to categorize the situation analysis, and while strategies to zero-dose children are categorized using the IRMMA framework. So this is our result based on our situation analysis completed from the PSC personnel. It indicates that the main challenge in reaching zero-dose children in Indonesia are data quality issue and also low health literacy. To overcome this problem, especially for data quality issue, the most proposed plans are for the coordination. It means that to have the great data quality, we need to cross-program and cross-sector collaboration. And related to the low health literacy, the most proposed plans are for capacity buildings, not only for the community, but also for the healthcare personnel, including midwife. And this is the total projection cost and the cost per child, although it was very overestimated. So we see that the total projection cost varied from the 43,000 to 155,000 US dollars. Significant variation in financing policies such as local transport and incentive for community health workers being the differences between one district to another district, and the geographical size and target population scale also influence the cost differences between the district and cities. And then reaching the zero children tend to be more costly in our data in urban area compared to the district. Reaching zero children tends to be more costly in district compared to the urban areas. And here, the Klaten district recorded the highest cost per CD child, while Bandung has the lowest. In Klaten, the cost is driven by the dispersed target populations, and we rely on outreach and mobile strategies. To the amount of funding gaps, and we also unable to distinctively differentiate between the zero dose specific activities and routine immunizations effort at the implementation levels. And some are integrated within the broader routine immunization delivery systems. And despite the lack of standalone interventions, many existing routine activities can simultaneously help reach these children, including the sweeping and also the health posts. And our current efforts to reach the Z populations are integrated into our routine services, but are constrained by the limited resources and human capacity at the service delivery level. And if you see in the graph, the gray one means the national transfers. The proportion of the national transfers, it's still the highest now. And secondly, you can see the yellow. Yellow means the village fund, which is currently contribute to the immunization services. And the orange are the PSC managed funds, which is currently utilized in some PSC. And the funding gap, we can see here, it's found in the Malang district, followed by the Semarang city. In Malang district, it is driven by the need for additional incentive for cadres, especially for the transport and also home visit. While in the Semarang, the gap is due to the need for community engagement and socialization, especially for in urban slum area. According to the strategy, we identify that the largest funding gap is found in the capacity building, followed by the coordination and also outreach. So, the policy implications, we can see that we actually can integrate the capacity building needs fund to the village funds. Why? Because currently village fund supports the community outreach, immunization as and posyandu or the post health posts, and also maternal child health programs. So we aim to strategically leverage to strengthen local health system through capacity building initiative from the village fund. And second, to accelerate the progress towards zero dose targets, the national budget planning should also be realigned to better address the subnational priorities, especially for the outreach and subnational coordination, because this area is currently under-resourced. And third, in Indonesia, decentralization context, our findings have catalyzed local policies currently initiated by the District Health Office leadership, encouraging the PHP leaders to mobilize available funding source at the PSC level, such as the PSC managed fund that before coloring orange, to maximize the program integration to support activities towards the zero children. Thank you, that's all from us.
Thank you so much. It's always interesting to see not only the localized sort of costs of programs, but also localized financing in a decentralized system such as Indonesia. Next, we'll move over to Pakistan, and we'll have two speakers coming up. We have Hania Qavi and Mohammed Salman from Impetus, who will be presenting on costing, outreach, conditional incentives, and trusted local pathways that lead to immunization.
All right. Hi, everybody. My name is Hania Qavi. I'm a senior associate at Impetus, leading the Zero Dose Learning agenda in Pakistan. And with me is my colleague Salman, who is an implementation leader, designing and implementing the costing study we will be presenting today. Since 2020, in Pakistan, significant investments have been made to gain advantages in coverage across the board, and we have seen that. However, as of 2024, we stand as a country with the second highest zero dose numbers in South Asia, just right after India. For our project, we work in Karachi, Sindh, which is the largest city, an urban center, and houses 20% of the high-risk areas pertaining to zero dose. For a little bit of context on where we are in terms of our project, we work in 3 union councils within this larger urban center, which are largely categorized by informal settlements with a lot of population density. You're looking at around 750,000 people in a very small union council that should technically have 15,000 out of straight. The average zero dose rate as of today is 13%, which isn't too bad. However, we've also noted that it's very persistent. So this last mile is now contributing towards refusals, and the system has tried extensively to convince them otherwise. However, the last year or so proves that the needle isn't moving. Our project has also done a lot of study and understanding not just what the problem is, but why it exists. And with that has come an understanding of who are the caregivers responsible for denying their children vaccination or are foregoing it for reasons we have also considered. Now, I'm going to take up some of the wonderful sharings from the India team because we are part of the Zero Dose Learning agenda. Our process was also to understand the human-centered design process that we could implement, and then also understand the drivers for why zero dose exists in these communities and is so persistent. For us in Pakistan, the problem is largely because of intent, if not all because of intent. And the top 3 drivers we have are the lack of trust in public facilities and health services, which means even though facility readiness stands at 95% and a vaccination site is available within 6 minutes of walking, people are not getting their children immunized. The second is there's limited awareness and persistent misinformation about the due merits of immunization and what it could achieve. And third and most important is caregivers prioritize the fulfillment of basic necessities like food and shelter over unseen problems that immunization can solve. We've co-created interventions through the processes that the India team has reflected on, which has led to 3 interventions in our sites. The first one is to improve ZD coverage by leveraging unlicensed, informal practitioners who refer people, caregivers who come to them, to immunization sites that are public health managed. The second is to use traditional birth attendants as a leverage in critical points in the 1,000-day journey to counsel caregivers to get their child fully immunized. And finally, to deal with the priorities that caregivers have, we leverage an existing social protection initiative called the Benazir Income Support Program to offer a top-up to parents quarterly for completing their child's immunization schedule. Without going into too much detail, I highly encourage questions on the methodology and what these interventions are. But over to my partner on the methodology.
So the ZDA intervention in Pakistan has really cost in Pakistan estimates the average incremental cost of vaccine implementation in zero dose child for the 3 interventions as I explained. The 2 interventions leveraging informal health actors, private informal health practitioners, intervention assistants, focus on engaging those actors, and for the conditional cash transfer program, we focus on the cost of mobilizing a household to determine the eligibility for the conditional cash transfer program. So to estimate the incremental cost per additional zero-dose child vaccinated, we measure two outcome indicators. The first is cost per additional zero-dose caregiver counseled or surveyed, and second, the cost per additional zero-dose child vaccinated. To evaluate the cost effectiveness of our UPL interventions, we also costed out the existing cost that government incurs for delivering the existing outreach services, and we did for that we conducted a baseline costing study involving at a facility level in 3 unit councils involving 9 facilities, and we surveyed frontline health staff. And we conducted this. We adopted a stratified sampling approach and also factored in randomization to account for differences in the variation in these unit councils. The study reveals that it takes up to $16 on average across the board, 24 hours to vaccinate a zero-dose child for the existing delivery outreach programs that government incurs. The graph on the right shows why these variation occurs across the 3 unit councils. So, for example, the actors that are involved, it depends on the actors that are primarily involved in those delivering those outreach services. So, for example, community-based vaccinators who go for door-to-door mobilization have lower per hour wage rate, resulting in higher time to spend on vaccination coverage. That is, like you see, a higher number with lower cost in the 2 unit councils in Muslim Islamia, whereas community mobilizers were tasked with and responsible for vaccinating, convincing more chronic refusals and have higher wage rate, have higher cost and less time across these unit councils. Interestingly, it is also important to note that community-based vaccinators, area supervisors, and CMs, community mobilizers, who are responsible for vaccinating, for convincing these zero-dose children, account for 19% of the time and cost for in the existing government outreach efforts. If we compare the baseline results to our ZPA interventions, primarily the 2 interventions, engaging informal health system actors, we find that leveraging actors that are rooted within the community and are more trusted by the community, such as traditional birth assistants, lead to lower cost per child vaccinated, because obviously they're more trusted by the community. There is a great better linkage established with them. If we go down by cost categories of the important core components of our intervention, we see that intervention input cost, intervention follow-up cost, and implementation cost are the 3 major cost categories. And interestingly, we also find that incentives cost generally are neither a major cost for per child vaccinated across the interventions, nor it results in an increased number of children counseled or referred by these practitioners, because they're already ready to work with us pro bono based on the relationship that was established with them.
Alright, so just to reiterate, the incentives in this case are the incentives we've provided for our partners in the intervention, not caregivers. We have not incentivized people to go and get their children immunized. This too, our partners were not incentivized or did not take us as an opportunity to perform better. Because they were interested in the well-being of their communities, we actually dropped the incentives, and therefore it's not a big cost component in our interventions. Now, coming to the conditional cash transfer part of this intervention. Our intervention does not hand out the transfer. The government already does that. All the intervention does is identify campsites or zero-dose clusters where the government can place these camps and better target people who could be eligible, and also promote immunization in that process. What you see on screen right now is results from 5 of these campsites conducted across varying union councils, and you see there is a lot of variance, which is a consequence of demographic differences, topography, ethnic differences, so time and cost will vary subject to that union council. What you see on the right most, and what's perhaps interesting in this case, is that the activities involved in conducting these campsites, the most significant cost contributor is counseling and mobilization. So regardless of what the government is currently doing, any additional activities like those that we've done or those that the government's already doing in the form of this involves a lot of mobilization and counseling, which is important because our primary driver was intent. So to solve this problem on demand, regardless of what we do, people will have to spend time and effort to try and convince individuals. What's effective, however, in this case is that this, because it targets a primary driver directly by incentivizing people, which is what they asked for, ends up being a very cost-effective model and is something we recommend doing at a policy scale. So from our learnings, which are preliminary for now, the first recommendation that we have is that to apply cost-effectiveness thresholds to scale up decisions for any actor outreach models. This is important because the actors in our context both have varying degrees of trust, varying degrees of efficacy in terms of the time they take to convince people, and have differentials in per diems or salaries. The second aspect is to integrate time-based costing into budget planning and HR allocation. We are currently in the process of the country to forego community-based mobilizers because it's a significant cost function. However, our costing exercise also points to the fact that they might be the cheapest. And they do a lot which isn't considered if you don't do such analyses. And finally, to consider human-centered design interventions, because if anything, our cost study points to the fact that when you target drivers directly, the chance of success, and therefore the cost entertained per child, is good. Thank you.
Great, thank you so much. And with that, we'll move into our final speaker before we move into the Q&A session. The next speaker will be Alex Adjagba from UNICEF, who will be presenting on the effectiveness of cash incentives for caregivers and increasing immunization coverage among zeros.
Thank you. Good afternoon, everyone. I hope the title is not misleading. I mean, if you read the title in line with my question for my colleagues earlier, it will be misleading. I'm definitely not a pro cash incentive, but the point here is to just ask ourselves the question of to understand from the literature if cash incentives work. I should not start a conversation before I ask you what do you expect when you ask this question. Because from the presentation I've seen since this morning, it has not been really clear to me if when we target zero dose children, if we really make sure that we are talking about the children who are getting the first dose, or if we are identifying sometimes children that already have one dose and then we have them complete. We have them complete the schedule. And I think that's one thing that we will see in the study. I didn't want to go through the slide, but if I was to make my moderator happy, I would just answer the question in 2 sentences by saying that there is a possibility that this will work, but the presentation I've seen during this whole day, I'm not being very reassuring. But this is to give justice to my colleagues who did this excellent presentation. They reviewed the literature to answer a simple question, sort of the gap in the literature. The gap was identified because people were in the zero dose conversation and the IHEA 2030 conversation. People wanted to understand if by giving cash to the mothers or the parents, you could really find those children who are so difficult to find in many countries. I went to the whole study, a whole systematic review. I will not read everything. I will just go for 2 points for each slide. The first one is about the definition of cash incentive. Just to make a difference between the conditional and conditional targeting. I will not go into it, but the point is that when we give cash incentive, are we really clear what we are trying to achieve? The main objective I would say is to really examine the impact, possible impact. quickly went through a number of studies. That was the first part, which reviewed the reviews that already existed before 2021, and then the international review between 2021 and 2025. More than 1,700 papers were found. I'm going to go through this just to show the different steps in the review. And then I will go straight to the result. I think it's important to have more time on the result. The cash incentive to the work to complete immunization coverage. Sorry to say that. The answer is maybe. Most of the time, no. The second question is, when the cash incentive were made to be really narrow, to focus on immunization, did they come out clear? I mean, does the impact come out clear? There were only 4 studies that went through that specific aspect. 3 of them were shown to have improved, to have found some zero-dose children. But we'll see in the next slide that when we talk about the zero-dose, most of those papers were not really clear. What were they looking for? Were they finding children? Were they unreached? It was not really clear. But one thing that came out clear is the timeliness. The timeliness was examined in a few studies, and it seems that by giving cash, I want to say enough cash to the parents, then it helped them complete the vaccination schedule on time. It's interesting to see that in the 18 studies that were retained as part of the final examination, we found that the amount of money that was given to the parents varied between less than $1 in one shot to almost $100 over many years. And that has an implication when we are looking at the data. The cost of intervention, very few of them reported on that. No meaningful comparison on the cost of the over the papers. Of course, there's some bias. I will go through that. I want to come back here just to say, number one, there is one thing that Prof. Shine today this morning said from the first presentation, which also came clear in this work, is that there is not 2 papers looked at this issue the same way. There is a whole difference in the design, a lot of difference in the implementation. The target of the intervention was not clear. It seems clearly that there is a need for someone to come to the point where they draft the guidance on how do we actually measure cash incentive interventions, and across different countries so that we will be able to compare them. The second aspect is about some of the papers showed some impact in Mexico and Honduras, but then when that same data set was reanalyzed, I think Logan was part of the reanalysis, it got a different result. So there is also an issue around how we analyze data. Then, in terms of a condition that are put together, to this cash incentive, sometimes the conditions were so targeted that it's obvious that after the funding is finished, we are not very likely to see improvement in the behaviors of those parents. So it brings me to my last point, is really to question ourselves around not just, 2 things maybe. The first one is, are we really answering the question that was asked by these parents when we took cash incentive. Because we do live in a very monetarized society, so do we assume that people will take the money and then do what we are asking them to do? And your presentation from Pakistan is interesting. I hope I will be able to ask a question being in the panel. Because you said that there was no cash incentive, and the government was doing that. There were 2 studies in this list that had the same sort of implementation and design. It was a broad intervention that was put together by the government as part of the poverty reduction and stuff. And those were the only 2 papers where there was a discussion around the sustainability of intervention. So this is the second point I wanted to make. The sustainability was systematically not examined in those papers. And the policy implications are very clear. I will not list them. But the policy implications don't want to show up. Sorry, it's not working. But the idea is that if we want to implement find zero dose children, we seem to, and we saw that since this morning, we seem to really want, we seem to have spent a lot of money in terms of finding them in Uganda and stuff like that. The question that I keep asking is, in certain areas, instead of spending money to incentivize the parent, have we looked into the comparator of using that funding to strengthen the system, or to strengthen, to do some sort of supply side intervention, to bring the service closer to the parent? None of the study looked into those aspects. Most of the time there was no comparison. And lastly, I will stop there, is the issue of the cost and cost effectiveness of this intervention. There was very, very few evidence, very little evidence around the cost and costing and cost effectiveness of those interventions. So that called for more work, more research, in case the communities, sorry, it's not working. In case the communities is going to go through that. I had one last slide. Yes. No, next one. Yes, I will finish here. Just my last point would be to thank my colleague who did this work. It's actually a paper that they will publish soon. I really think there is a lot to learn from the community in this work. Basically, are we walking in the land of the blind when we have cash and we really want to find the children? Thank you.
All right, thanks everyone. I'll call the speakers back up so we can get into some questions and answers from the audience. Just sit up here. So we have about 20 minutes. I'll take some questions, but first I'm going to ask one question to everyone, just to get some quick feedback on that. So the first presentation, we saw that there are financing gaps in places. We're not financing enough for the cost of the programs. In the second presentation, we seem to show that incentives maybe don't matter so much, that people are intrinsically motivated to kind of deliver the services that we want them to deliver, and that for the workers, incentives didn't seem to matter, and then for caregivers or for people, incentives came from elsewhere. And in the last presentation, we saw some mixed evidence on incentives, like maybe they work, maybe they don't work. Maybe we need to target them better. My question for you all to answer real quick is, should we just cut incentives altogether? Is it worth doing? Is this money being wasted in a climate of reducing health financing? Should we be considering scrapping this entire idea? Sort of what are the pros and cons of that?
I can start about the gas incentives. So actually, we also have the dialogue with the district health office in our priority district, and they actually do not support the cash incentive for the parents or caregivers. But if the cash transfers are given to the caregivers or the community health workers, they still have the potential to reduce the zero-dose children.
I'm going to have a complex answer because I think my intervention's a little complex. We work in communities where, this is not to exaggerate, but children barely get a piece of bread maybe once a day. And there is acute malnutrition, and we've seen how not just the intervention we're proposing, but because the government is already deploying the social protection initiative, it does make a difference. It's the choice between having 2 slices of bread a day and having none for some families, right? And for our case, I would encourage everybody actually to definitely look up the Benazir Income Support Program. This is not to credit myself, but the government of my country that has deployed this for more than a decade now and has found robust and significant impact in alleviating a lot of the concerns women have when it comes to financial access and choosing to spend on children the way they want to choose. The deliberation here, and I do like that question about whether or not we should leverage it, I think it is contingent on the fact that you do it for the right reason. It works for us because the primary driver we have established is that the community thinks the government is reinforcing immunization again and again and is ready to come to their doorsteps every single day but cannot offer a slice of bread to their child who's starving. That is the differential here and why it seems to be working. It is still preliminary, but in this case I would say let's keep it. Yeah.
Thank you. I think your answer actually brings back the question of what are we doing with this cash incentive? Is it just a poverty alleviation method that the government wants to use? Because what you are describing is poverty. Are we trying to accumulate a capital, so basically, are we really talking about vaccination or immunization? It's completely work. There is a lot of evidence out there to show that cash incentive can reduce poverty and then can bring many benefits to a household, especially in terms of decision making and healthcare access. But the question was, is cash incentive working to find zero-dose child and to vaccinate him fully? To that question, in this environment, financial environment, my answer is no. I want to say it depends, but it depends on so many things that it's closer to no than to yes. Thank you.
Great, thanks for that. We'll take questions from the audience now. Salman.
Thank you very much for your brilliant presentations. Please, I want the second presenters. You mentioned the incremental cost somewhere, and I was wondering if you consider baseline cost, or are we just looking at average cost? So I will need a clarification on that. Thank you.
Thank you very much for all those really great presentations. I wanted to follow up on what Alex said, because I think we can't just lump all cash incentives into the same bucket. I think there are very different types of cash incentives, and I think the social safety net programs that offer incentives to or payments to families as part of poverty reduction, I think represent an excellent opportunity to add an immunization focus into those, because the incremental cost is very small. We're not paying for the whole system, and by bringing that added dimension, it helps to drive additional vaccination. Now, whether or not it's only for zero dose or for wider immunization, I think whatever is useful and doesn't represent a huge cash outlay, because it's a very incremental cost would be a win-win in my view. And I think we have to be careful about kind of comparing apples and oranges in this case, because kind of standalone cash, transfer programs that might be donor funded, might go away. Those are very different kinds of programs than the long established kind of government programs. I did have a couple of questions. So for the presenter from Indonesia, you talked about, sorry, get my notes here. You talked about the need for capacity building activities, and I'm wondering if you could define what those are, what kinds of activities those would entail. And did you ever evaluate the cost of the zero-dose program that you estimated with district level budget? Like what proportion of that budget would it represent? I'll stop there.
Maybe we can stop and have them answer those set of questions first, and then we'll get the second round.
So I'll go with the first question, which basically asked about incremental cost. So for incremental cost, we only covered the delivery cost of the interventions that we are conducting and leveraging informal actors. And this does not include programmatic costs such as vaccine supplies, which are already in our study established that they're already there. It is the question of intent of the people to have or not. Similarly, the baseline results that we also showed were reflecting the delivery cost, not the vaccine supplies cost, the vaccines and related vaccine supplies cost. So the incremental cost basically is the delivery cost to reach those zero-dose children and to generate the demand for vaccination.
It was not a question, it was a comment from Logan. But Logan, I think we are actually aligned in the conclusions. So what I'm saying is that based on the evidence that we have now, there is so much disparity, there is so little alignment in the papers. It's really difficult to answer that question. Even what you're saying is the assumption that it's a marginal cost, it should work. But when we look at this data with regard to the specific zero-dose agenda, that was my presentation, I didn't have enough evidence. But what you're saying, and which I agree with, is that we should find a way to do that more systematically, to do a couple of studies in certain areas, like you guys are doing, but something that is implemented by the government, something that is implemented by partners, and maybe see further what we are finding there. And I don't want to say as part of the zero-dose learning agenda, but some things should come from that part to be more systematic. Thank you.
Sorry, I will just take this chance to steal 30 seconds on what exactly the intervention is. The intervention is a top-up for a cash handout that is given if you are eligible on a quantile score, and very robust methodology. No comment to either of you, this is just me explaining the intervention. What it does is, if you are found eligible and you have a child under 2, you just get an extra $10 every 3 months if you get your child vaccinated. So regardless of that, you get the base unconditional cash transfer, and then should you have a child, for every child you get a slight top up. That is where we come in, is we ask the government to deploy these surveys and these camps in areas where high zero-dose concentration is found. That's it. That's the intervention.
Sorry, can I just add one more thing? Just a quick one. It's really quick. I just wanted to say that in a context where we have many countries where village health workers, many of them get paid $50 for 3-4 months. Many programs are struggling to be institutionalized. In those kind of settings, I would imagine that spending so much money for cash incentive with uncertain result, there should be a comparator somewhere where we say, if you use that funding to pay village health workers, they know the people, they will find the children. The issue we are having is that we are not supporting them. Many of them have performed so well that we have seen the result and then we forgot them. The question is, can we compare that cash incentive program to something which is not a theory or a principle? That's what I am done. Sorry about that.
All right, we can do some more questions.
Thanks. Mine is to the Pakistan team, and it's linked to Logan's point, where we're trying to leverage what is already in place. So you may not target the incentive to immunization, but you may, basically cash plus, may have some additional interventions around the cash, maybe give them education. So I wanted to understand in terms of your design, what plus components do you have that the immunization program is benefiting from, which of course then also leverage from the benefits of the social assistance program.
We have to come back here.
All right, thanks to all the presenters and those that made comments. Ms. Stanley Izamura from Results for Development Nigerian Country Office. So something striking in the course of this conversation would be, which has always come out to be, is incentive the way to go. $10 as incentive, that's the cost for PCV vaccine per dose. And we are using some of this money to do demand generation, where people haven't eaten. And for me, what's the sustainability? So to you, from all of the reviews, what were the sustainability plan for all of the incentives that you've seen? The second part would be, I think for me, so I support vaccine financing in Nigeria through the National Primary Healthcare Development Agency. So what is striking to us is, rather than fragment immunization and do resource mobilization and do demand generation, why not do insurance? Put into the benefit package. We all can attest to the fact that the mothers will always come to the facility for care. They will come with the babies. It's a complementary package. Before you do the fast, that's we're really doing that in Nigeria. We've incorporated that into the basic minimum package of healthcare service. If you come for your care as a mother, the child gets vaccinated. So we're using that to target all the children. So rather than doing demand generation, we use that money to invest into the pool of vaccine financing, to get more vaccine that will be available at the facilities for the mothers to come, receive the benefit package, and the children are vaccinated. So these are the few points I'd like to raise.
We'll take one more before we. Actually,
thank you. My question is to Hania and Salman. I think it was, you mentioned clustering of zero dosers, and in our experience when we tried that in India, we couldn't find a point of confluence. We thought access would be that, and we tried isotopes mapping, used satellite images, realized they spread all across. It could be very near the facility, it could be very far from the facility. In terms of demographic characteristics, it's very difficult to come up with statistical models that can combine all of those demographic characteristics and cluster them. So it would be super interesting to find out what those clusters look like for Pakistan. Also, I think we missed one question from the Child Indonesia team, I think. So as part of the previous series. So if we can get an answer to that also, that would be great. Thank you.
Right, we'll stop there and hand it over to the panelists.
I can take the first one. My colleague from Nigeria. Just very quickly, The first one is that Nigeria did try cash incentive. I learned that during the coffee break just now, incidentally. And it was dismantled by the following president, right? So this is kind of answering some of the sustainability issues. Number two is when Kenya did a pilot for UHC between 2018 and 2019, one thing that came out is that mothers were coming because care was free. They were coming because healthcare was free. They would come for diarrhea and then they get vaccinated. So we wrote a paper on that is coming out soon. But the question that we are asking is, and ultimately, the best incentive is free healthcare. So if you, as Gavi, as Global Fund, as Gate Foundation, if you really want to put money into cash incentive, maybe you can use it to support free healthcare, so that people will, if it's free, people will come. That's what you are saying, basically. I think that's, I agree with that. And on the insurance point, and the sustainability one. So UNICEF is, I want to say, I hope I won't get fired after that. UNICEF supported village health workers in Zimbabwe country office for more than 10 years with money from different donors. There is a pool fund, so many countries were participating, and UNICEF was the fund recipient and the fund manager. I was the chief of health and nutrition in Zimbabwe for 3 years. I can tell you, we spent 3 years looking for money to pay village health workers, because for 10 years, they had UNICEF name in mind. Like UNICEF pays us for every 3 months. So when the money dried out, everyone was calling. When you go to the field, people are asking you, UNICEF, where's my money? But it was, you see what I mean? Sustainability, even for a big organization like UNICEF, was not there. And that came out through the paper. All the papers were showing for the small project, small scale project. It was showing clearly that sustainability was not something that was properly discussed. It was, the intention was probably there, that the government will take over, but we know that the government will not. And then the last point is the insurance. We proposed in Zimbabwe, we proposed to the government that there should be a healthcare benefit package, that we should actually consider paying the village health workers through insurance. Because if people are paying premium and people know village health workers and they believe, they trust village health workers, they will not have a problem to have them paid through the premium. That is being considered at the moment. We will see how it goes. Thank you. Sorry.
Okay, I would like to answer related to the capacity building activities that are being proposed by the BSC. So they are proposing the capacity building or empowerment for the healthcare, for the community health workers or the caregivers. So we are currently lacking of money for doing the community empowerment from the caregivers. And the second is to have the training for the vaccinators to give education for those who are resilient to the vaccination. Actually, the same with the other country in Indonesia, the zero dose is mainly because of the vaccine hesitancy, not about the access, especially in Java Island. And the third is about the evaluation. So we currently haven't evaluated the cost. However, we aim to evaluate whether the funds is secure or not, and what is the proportion of the district levels contributions to the zero dose activity funds. However, it will be held, I think, in the end of this year. Thank you.
We had a list of questions. So to the first one, that was on what else can be added to this. I think that's a great idea. To be fair, the condition for the intervention we're currently doing with this is immunization, but it's meant to support mothers with improving their child's nutrition and to enable them to choose to enroll their children should they be interested in enrolling them. I think to add a further condition to this top-up is worth exploring and something we can actually take back. There was also a question on whether or not insurances would work. We've had spells of insurances that were government funded and unfortunately had political affiliations. So every 4 or 5 years it gets renamed or it gets canceled and then it doesn't work. Which is where BIS fantastically has not suffered in the last 15 years. It's surprising to us too. And to the question on clustering, I'll let Salman take that.
I think the point, interestingly, what we generally see across the ZDNA drivers was it was the intent that came up as not the major reason for not vaccination, and for across the 8 shukes that we have in Karachi and the 3 that we are working in for ZDNA project. All of them have primarily migration from north of Pakistan based on IDP population given the war time and so on. And then because of that, given that that same demographic generally holds across those population, they have that confluence. And then we also looked at access. We had points about coordinates about where outreaches are also located from existing government outreach program, and also monitoring evaluation data on availability of services. All of those pointed out that services are generally available, and then therefore it is the intent drivers that make sense. And again, those clusters have that very same demographic of migration from the north to south.
Can I also just add to that? So we're one of maybe 2 countries that still has polio. We leverage a lot from the Polio Eradication Initiative, the PEI program. They do monthly campaigns that go door to door, literally mapping how many children are born in each household, their ethnicity, what language they speak, where they live, when they went on holiday. There's a lot of data that's generated which helps us in EPI, on the EPI side of things, understand what these clusters look like, and on a monthly basis, see how they shift in terms of concentration, priorities, preferences, and reasons for refusal.
All right, thanks everyone. Just to keep to time, I think that's the end of the session, if I'm right. Yes, so that we can move on and be able to close out on time. Thank you everyone for